And welcome back to the Full Code Something. Today, and forgive me, I am not feeling stellar coming out the other side, but gonna sound a little more deeper than I usually am. So what I wanted to do today was to go and do some case studies, probably just do one. I was kind of inspired by some of the reels I saw of people going through and doing Doctordle. And if anyone hasn't heard of Doctordle, you can just Google it. It's open access. I'll share my screen in a minute so you can see exactly how to spell it. But basically, it's a diagnostic guessing game. Now, I think things like this are really good. I wish more of them existed, just because it kind of helps keep your brain functioning, firing in a clinically proficient way, or it can at least keep the wheels moving, especially when you're maybe not on service or you've been away for a little bit of time. It's always important to keep your diagnostic thinking up to snuff, especially if you're in an area that's very broad. So like for me, who I do medical ICU encompasses a lot of things. And it's not only that, like we care for patients in neuro ICU, we care for patients in cardiovascular ICU, depending on what their needs are, and we assist in all these patients. And if you just look at the MICU patient population alone, it's a lot, but if you add into everything else, there's a wide breadth of knowledge that you need. So going through something like this can be very helpful and kind of keep you on your feet. Now, full disclosure, this is my second time trying to record this. I am going to do the same case just because I thought it was pretty good. But that way you know that I already know what the answer is, but I wanted to kind of talk through it. Now, in case you're not familiar with Doctordle, I'm going to go ahead and share my tab so that you can see what I'm looking at here. Now, perfect. So we have a question. You basically get to take a shot at what you think it is. If you are wrong, it will give you another clue. If you're right, then you just get it right. Now, my original plan, and I'll probably stick to this for now, is to, even if I think I know what it is, I'm not going to say it maybe until we get closer to the end, so we can do some practice with thinking out loud and trying to create an appropriate differential diagnosis. This one is kind of tricky. It's definitely not an ICU problem, but there are definitely plenty of clues that can point you in the right direction. So we'll start. There is a 65-year-old man who presents with new onset pain in his back, hips, and knees, as well as hearing loss. Now, those are kind of two wildly different things. And if somebody popped in and was saying that to me, I'd be like, okay. And then I'd have probably a million other questions. And this is kind of the beauty of Doctordle, is you don't have those things. And, I'm hoping in the future we can go through like, not related to this podcast, but there's full code medical simulation, which gives you the opportunity, I think, to flesh some of those things out a little bit more. But this is kind of just raw guessing power, because you can't ask, you can't query in any way. So, back, hips, knees, hearing loss, let's keep it simple and we'll just go straight for trauma, which is what I chose the first time because, I don't have much else to go on. So we'll type in trauma. Oh yeah, that's right. There is no blanket trauma. There's no mechanical fall. So we're going to choose something that we definitely don't think it is, which is a subdural hematoma. Now, that being said, and this is also just kind of a disclaimer for as you go through this, just because a diagnosis is present or likely present doesn't mean that is the diagnosis that they're looking for. And that will apply to this situation, because you are going to see something that implies that there is another disease process going on, when in fact that disease process is a secondary function of what the primary issue is. So we'll just keep that in mind. Also, you are not always going to be horribly off base if you're just shooting into the wild, in the sense that you truly don't know what the next prompts are. And you might say something like this, like subdural hematoma, even though it's very obviously not it. And then the next one is some sort of neurological clue. And you're like, oh, okay, maybe I'm in the ballpark at least. So subdural hematoma, that's not it. Second, he has no significant medical history and denies trauma. So they took trauma off the table right away, which is nice. That's very helpful, but it definitely means that this is a body medicine problem. We have to try and figure it out. No significant past medical history, which is a statement that I absolutely detest, because especially in this setting, it doesn't specify, is this because you see a doctor and you actually don't have any significant medical history, or have you not seen a doctor in 50 years and that's why you don't have any medical history? So just because it says no significant past medical history doesn't mean that the patient doesn't have a significant past medical history that is unknown to him. So in this case, he has no significant history and denies trauma. So I'm going to kind of follow the similar track that I did before. I'm going to throw out osteomyelitis. I did not think it's osteo, but I want to flesh out some more of these clues. 3, physical exam shows frontal bossing and tenderness to palpation of the right hip. Now, this is the one that cued me in to my initial suspicion for what was going on here. So let's dissect it just a little bit. You have frontal bossing. So frontal bossing, I'm trying to think of an easy way. It's the difference between a big forehead and a pathologically big forehead. Maybe you could think of the term embossing, to emboss something. In my mind, those things kind of match up a little bit with your skull becomes more more anterior and laterally protuberant. It definitely, if you have a chance, Google it. I could always put up a picture, but just Google frontal bossing. You'll see large, kind of bulbous forehead. Sometimes you'll see it in children. Sometimes you can have premature closure of certain fissures that are going to push your skull in different ways as you continue to grow. The other thing that you can consider is something that causes a remodeling process. When we're talking about, and this is always something to consider, when you have a patient who has, let's say, clubbing of the fingers or a barrel chest, you know that those things didn't happen in hours to days or days to weeks. We're talking months, likely years, to develop those morphologic changes from whatever's driving them. When we think about bone, we can think of the same thing. This is kind of giving some evidence that there is a connection within. I don't want to give it away right away, but so it's implying that there's an underlying like osteoclastic process going on. And how do we know that? One, we're seeing frontal bossing. Frontal bossing is remodeling of the bone. There's something going on that is chewing it away and it's reforming itself. This is further bolstered by the fact that this patient is experiencing musculoskeletal pain, has focal tenderness in the right hip, which concerns me that there's a pathological, potentially pathological injury underlying that. And then there's also the presence of hearing loss, which might, to a lot of you, not feel connected, but hearing loss may not be sensory neural. It may be something that actually is from the degradation of maybe one of the structures that supports the hearing apparatus, which is something to think about. So I'm going to throw, what's a good guess to just throw? Is pathologic fracture? No. Let's say fracture, femoral neck fracture. I don't think it's a femoral neck fracture. I just want to get some more clues on the table. So we have serum uric acid and parathyroid hormone elevations. These are both also very helpful in trying to diagnose this. When I mentioned earlier about clinically relevant disease states that are underlying, but not the target disease, this is what I'm talking about. When you're seeing elevated PTH, it's very likely, and it will play out, that this is going to have kind of a secondary well, that kind of gives it away if you already know the direction we're going, but a hyperparathyroid picture. Serum uric acid turnover can be from turnover. There's different metabolic processes that are ongoing, and especially when you're talking about ones related to osteoclastic activity, you're going to have elevations in your serum uric acid, and if there's a process that is driving a need for some type of augmentation of the flow of calcium, then you can have elevated PTH or a secondary hyperparathyroidism. So I'm going to throw that down just as the guess. That is not secondary hyperparathyroidism. That is not the diagnosis, but it is a part of this. Next clue. Laboratory studies show markedly elevated alkaline phosphatase with normal calcium and phosphate levels. So elevated alk phos is also another thing that is kind of specific to this underlying process going on. That being said, is it to the realm of sensitive and specific? Is it sensitive or specific? That's a question that we can't really answer with what we have in front of us here. Normal calcium and phosphate levels, which we know calcium and phosphate are very tightly linked when it comes to matters concerning bone and calcium. So the real hint here for us is the elevated alk phos. We'll throw out one more so we can get the let's see, I already guessed it. Let's go throw out osteoarthritis, get the last clue. So, radiographs demonstrate mixed osteolytic and sclerotic changes with cortical and trabecular thickening, as well as a subtrochanteric femur fracture. So it sounds like we have a pathologic fracture or pseudopathologic fracture. We can correlate that with the focal tenderness to the right hip, even though it doesn't really tell us what the laterality of the findings are. But we are seeing a picture of bones that are weak, bones that are breaking down, and bones that are remodeling. And the findings that we have to also support that. So we'll go with the final diagnosis, which is Paget's. Paget. Osteoitis deformans. It's funny that it said I guessed the other one, but didn't guess this one. Submit. That is correct. So interesting case. Not that Paget's has ever impacted anyone clinically in the ICU, except for when somebody develops a pretty severe injury secondary to weak bones. But it's just me again. So I honestly am not going to waste anyone's time unless you're truly interested. Then drop a comment below and we'll talk about Paget's disease. But other than that, just food for thought, things to think about. So if you found this interesting or helpful, leave a comment, let me know. I'm going to try and do more things of this nature, things that are a little bit more pragmatic, even if it's not always the ICU content that we're always looking for, but things that help us think through problems. So thanks for tuning in. This has been fun, as always.